Good morning. Today our topic is zygomatic complex fracture. The learning of study is regarding about the etiology and anatomy of zygomatic fracture and the clinical and radiographic findings of zygomatic fracture. And so how you manage the zygomatic complex fracture with reconstruction, everything. So what are the main things we study in the zygomatic complex? Means the introduction of zygomatic complex fracture, anatomy, etiology, clinical signs and symptoms, clinical evaluation, radiographic findings, and the management. So what anatomy of zygomatic complex? Mainly there are four bones attached to the zygoma, that is one is temporal, orbital, maxillary, and the frontal bone. So these are the four bones that attach to the zygoma. It is the most common facial fractures. Secondly, the frequency after the nasal bone. The most frequently fracture site is the nasal bone. After that, the fracture is the zygoma. Then it's a high incidence because of the most prominent part of the face is the zygomatic bone. The incidence mainly of the cause, age, sex prediction are the main things. According to the age, the people having working atmosphere, everything they varies. They likely most the social, economic, and political and educational status of the population. Mainly the buttresses. There are two types of buttresses: horizontal and vertical buttress. Mainly by the nasomaxillary, zygomatic maxillary, and pterygomaxillary. These are the main buttresses support the facial skeleton. And the outer convex surface and the inner convex surface are there. The convexity of the outer surface forms the greatest prominence of the face. If anything will happen to the zygomatic bone, it has the chances of loss of function and aesthetic, because most of the inside the orbit there are muscles like a lateral muscle attached to the zygomatic bone. So if there will be any zygomatic bone fracture, that will lead to loss of function and the aesthetic. Since the growth shape of the face is influenced by the underlying osseous structures, so the zygoma has the most plays an important role in the facial contour. So, what are the main causes of zygomatic complex fracture? One is road traffic accident, next by assaults, next is work later, and fall from the fall of the building, and sports injuries like at boxing and hockey, everything. So the fracture patterns are in two types, mainly by the direction of force and magnitude of the force. The fracture passes through the areas of the greatest weakness or between two bonds, mainly on the suture area or the most weakest bond. In this, these are the two areas the fractures will be seen more. Zygoma being the most strong and fractures passing in the adjacent to articulating one is mostly seen on the fissure region. So the pattern, first the infraorbital fissure is the key part of the zygomatic complex fracture. There are three lines of fracture. First one, anteromedially the orbital process of the maxilla towards to the infraorbital rim and goes to the orbital, and the medial walls of the orbits are commuted. Then it passes the infraorbital canal is caused by the fracture line to the reach of the facial surface of the maxilla, medial to or above the infraorbital foramen. So the fracture might be going inside or be above or below. From the infraorbital rim that goes laterally and inferiorly to reaches the zygomatic buttress. The fractures rarely involve the zygomatic bone. It's a very rare case, the fracture line seen on the zygoma. Next, the second line from the infraorbital fissure goes posteriorly, joins to the fracture of the anterior aspect of the maxilla under the zygomatic buttress. Third one, the superiorly from the infraorbital fissure along the lateral orbital wall, posterior to the rim, separating the zygomatic sphenoidal suture, extending superiorly, and laterally and anteriorly towards the lateral orbital rim, separating the frontozygomatic suture. So these are the main three lines that leads the zygomatic complex fracture. So next one is the zygomatic arch. That's the most weakest part of the zygomatic arch. Zygomatic arch is 1 centimeter length more close to the zygomatic to the temporal suture. So in between there is a zygomatic temporal suture is there. Next one is the terminology what will tell about the zygomatic complex fracture. One is zygomatic maxillary complex, zygomatic maxillary compound, zygomatic orbital, trimalar, tripod, zygomatic complex fracture, and zygoma fracture. These are the main terminology used for the zygomatic fracture. According to the classification, they are divided into Rowe and Williams, Larson and Thompson, and Munson et al. These are the main classification based on the zygomatic fracture. Next one, the signs and symptoms of the zygomatic fracture. Mainly, the signs and symptoms depends on the degree of dismay. Might be it goes to inward or could to the outward. So, main symptoms pain on the particular area of the bone. Next, the pain it is due to might be injury to the infraorbital nerve because already we mentioned about the fracture length that runs infraorbital rim and goes to the above or below the infraorbital rim. So might be there will be chance of the fracture site entering to the in between the fracture. That's why infraorbital nerve. Next is the trismus will be there and epistaxis will be there. Then the flattening of the malar prominence, there will be, you can see there will be flattening on the particular region, flattening on the malar prominence will be there, and there is a flattening on the zygomatic arch because the fracture site goes might be inward, so that should be the flattening of the zygomatic arch or the malar prominence flattening, and deformity over the infraorbital rim. If you palpate, you can see there will be a deformity on the infraorbital margin also. Then displacement of the palpebral fissure. If you check all the palpebral fissure, there will be displacement will be there, and if you clinically you can see there will be your unequal pupillary levels because you can see the level of pupil will be change because the zygomatic bone is attached to the some of the orbital muscles. So if there will be fracture on the zygomatic maxillary fracture, no, so it goes to the downward. So the pupillary level will be down, and parietal edema will be there. Subcontinental ecchymosis, diplopia like a double vision will be there, and enophthalmos because the contents of orbit going inwards, and ecchymosis of the ecchymosis of the maxillary buccal sulcus. If you see intraorally, you can see there will be hematoma on the buccal sulcus on the maxillary region, and emphysema deformity of the zygomatic buttress. So, how will you clinically evaluate the zygomatic fracture? If you evaluate on inspection and palpation from the superior, inferior and lateral frontal vantage. So if you check on the superior view, we can palpate the projection of zygomatic body anteriorly and laterally, relation of the supraorbital rim, palpate of the supraorbital rim and infraorbital rim, compared to the other side. If there will be any deformity or any step deformity, that means the side will be fractured. Place of this finger over the body of zygoma infraorbital ring, pressing into the edematous tissue to compare the position of the bone. Compared to the other side, we can see there will be any deformity, that means that it will be fractured. So, after the clinical and evaluation, we go for the radiographic evaluation. What are the radiographs we will take for the zygomatic maxillary fracture? Mainly by occipital mental view 10 degree, caudal loop view segmental vertex view, CBCT, 3D CT, like that. Mostly the common one we are using is oximeter-mental view. In oximeter-mental view, in the radiograph, we can identify the Campbell and Trumbull lines. These are the 5 lines. Campbell line, the first 4 lines, 1, 2, 3 and the 4. The 5th line is called the Trumbull line. So the first line that starts from the frontozygomatic suture goes to the supraorbital margin, then for the frontal sides and to the other side. Second line starts from the zygoma infraorbital margin, maxillary sinus and goes to the other side. Third line goes from the condyle, cornoid, maxillary sinus, floor of nasal cavity and to the other side. Next is the ramus and to the occlusal plane. Fifth line, the lower bottom of the mandible. So this is the important part in our oximeter mental view. Campbell and Trumbull lines, there are 5 lines. Then only we can identify where is the fracture line. If there will be fracture line seen on the second line, that means there will be fracture on the zygomatic arch, infraorbital ring and nasal cavity. So we can see in this radiograph where is the fracture line. We can see there will be discontinuity on the frontal and the zygomatic, and there will be discontinuity in the zygomatic arch, like that. So that means there will be discontinuity on this area. That means the line from the first line and the second line, like that. So the main principles in the treating of zygomatic fracture is first one, prophylactic antibiotic. This is very important because most of the road traffic accidents cases there will be chances of susceptibility of infection. So you give strong antibiotic coverage. And there will be paresthesia will be there. So under anesthesia only we can do all these. Then clinical examination of and force reduction test. Force reduction test is used for the entrapment of any muscles in the orbit. We will relieve from the fracture. Otherwise, there will be chances of difficulty in the movements of eye movement, and that will lead to sometimes blindness also. And antiseptic preparation, you giving mostly the betadine solution for the preparation. Then the reduction of fracture. Then the application of fixation device might be there will be mini plates, there will be wiring, like that. Then internal orbital reconstruction. If there will be countries of the orbit, means the floor of orbit is very thin, so there will be fracture on that area. We will reconstruct with the titanium mesh or mini plates or graft. Then assessment of the ocular mortality. Check the movements of the eye movements. If there will be bone graft, we will be using extra-orbital, which is defect, reconstruct with the bone graft, and soft tissue resuspension, and post-surgical ocular examination, post-surgical image. The most surgical approaches are mucosal incision. There are 2 types of mostly maxillary vestibular approach and trans-conjunctival approach. Maxillary vestibular is called King's approach. Trans-conjunctival approach, we have incision place inside the eye. Dermal incision like a supraorbital incision. Gilles temporal approach is commonly used for the zygomatic arch fracture. Then subtarsal, subciliary, coronal. If there will be bilateral fracture on the zygomatic arch or zygomatic maxillary complex, using bicoronal. With the fracture suspecting on the supraorbital or frontal or nasal, we are using bicoronal incision. Maxillary vestibular approach is the incision placed on the vestibule. This incision frame placed frame might be from premolar to premolar because there will be incision. If the fracture site is more, the incision will be more. So the incision placed on the one side reflect the periosteum using with the periosteal elevator, Morse periosteal elevator, and identify the fracture and placing with the plates. Before that, we must stabilize the occlusal level using with eyelet or arch bar. Then only we can stabilize the fracture site. Next one is the trans-conjunctival approach. The trans-conjunctival below inside the lower eyelid, we are incision is placed on the conjunctiva, and after we reflect the adipose tissue and identify the infraorbital margin, because if there will be fracture on the segment, the infraorbital margin is also intact, so we are inserting the plate on the infraorbital rim, or might be we are using that graft or titanium mesh. Subtarsal incision. The subtarsal incision is placing below the lower eyelid. You can see the incision, and we are reflecting the orbicularis oculi muscle, and then identify the fracture site and placing the mini plates. Gilles temporal approach is the most commonly used approach what we are using. Gilles temporal approach, the incision is placed on the temporal region, where incision is placed, a small incision is placed, but avoid the superficial temporal artery. Then we are reflecting the superficial temporalis fascia, then it goes to the deep temporalis fascia, then you can see that temporalis muscle. So up to that superficial temporalis fascia, deep temporalis fascia, then you can see temporalis muscle. In between the deep temporalis fascia and the temporalis muscle, we are inserting the periosteal elevator and pass to the inside the portion of the zygomatic arch. So inside the zygomatic arch, we can identify the might be there will be inward of the zygomatic zone. So we can elevate the passing in the temporalis muscle. We can invert outward the zygomatic arch to the outside, so we can maintain the fracture. But between in placing, you are using the periosteal, you placing a course, it's used as a fulcrum. Otherwise, there will be chances of injury to the temporalis muscle and the surrounding tissue. Next is a supra-orbital incision. Might be the most of the type there will be incision not needed, because sometimes there will be maxillary fracture. Already there will be laceration will be there. In that type, we will reduce the fracture through the laceration. Otherwise, we are putting the incision. In supraorbital incision, the incision is placed on the supraorbital rim and identify where is the frontozygomatic suture. Might be the fracture site on the area of frontozygomatic suture area. So we are using with the 2 hole with the gap mini plates are commonly used. Coronal incision. The coronal incision mostly the incision is placed from the preauricular region and goes to the temporal, parietal, and goes to the other side. The coronal incision most commonly the incision used for there will be zygomatic arch fracture, supraorbital rim fracture, so frontozygomatic, nasal, and the frontal sinus fracture like that. And might be there will be temporal fracture or the frontal bone fracture will be there. In that type, there will be suspecting head injury, hematoma will be there. So in this fracture, in this type of like a Lefort-3 fracture or Lefort-3 with the zygomatic complex fracture, we are using this type of bicoronal incision. This will take too much time, and also we are giving in the preauricular incision, we must preserve the facial nerve, because the facial nerve trunk is passed between the external meatus around 1.5 centimeter to 3.5. So the main trunk is passing here. So we'll avoid the facial trunk. Otherwise, the sense of facial nerve paralysis will be there. Next, the method of reduction we are using is the temporal approach. That's called Gilles temporal. Already I mentioned in the Gilles temporal approach we are using the periocellular. And the most commonly instrument to elevate this zygomatic is called two instrument called a Rose zygomatic. This is the Rose zygomatic elevator or Bristow elevator. In Bristow elevator, the handle will be not there, only the blade will be there. This is to identify where is the actual point of the beak, and also we want to elevate the fracture. So we are placing this Bristow elevator in between the below the zygomatic arch, and we will elevate with this handle so we can reduce the fracture site. Then without there is a handle, we are using only the Bristow blade and placing it into the zygomatic arch and put force so we can reduce the fracture site. Next, this one is the percutaneous approach. This is the old technique we are using, only that using with a hook and elevate it. It's called malar hook or Coronal bone screw. Next is the buccal sulcus approach, was called keen approach. It's 1909 the first done. This is that we are insertion is placed on the vestibular approach on the maxillary region, and placing that periosteal elevator placed in between the middle side of the zygomatic arch and push it. So what will happen? The fracture site, this one goes to the normal position. So there will be no placement of the fixation of mini plates. Sometimes if the fracture is can never reduce with using with the breast elevator or periosteal elevator, using with the mini plate on the vestibule, means the maxillary zygomatic arch region. Next is the elevator from this eyebrow approach. Where the elevation is done, we are using the supra-orbital incision is placed, and below that we are using that Dickman zygomatic elevator and place it, and the fracture site will reduce with using inward and outward motion of the elevator. Next, the point of fixation of the mini plates. Mainly the fixation of plates we are using on the frontozygomatic region, that we are using with so many materials we are using, like 2 hole with the gap, 4 hole with the gap, like that. So we are using one plate on this frontozygomatic. Next, the fracture site will be seen on the zygomatic maxillary region. So in that area we are using commonly L shape. But this type of fracture, what will happen? There will be fracture of the maxillary and the wall will be fractured. So we are placing towards the posterior region, we are placing here that L-shaped plate. And also, if there will be we can reduce the fracture seen on the orbital region. In this area we are using that infra-orbital ring. We are using the same 4 hole with the gap. If there will be fracture on inside the orbit, we are reconstructing with the titanium mesh or graft. Otherwise, there will be chances of contents of the orbit going towards the maxillary. That is called a blow-in fracture or blowout fracture. So these are the main areas the fractures site the plate will fix on in the frontal, maxillary, infraorbital, and the zygometry frontal. So these are the main things we are telling. So I will concluding the main things we are telling about the first is the anatomy and what are the causes of injury to what are the causes for zygomatry maxillary fracture, and what are the direction. These are the main important thing. How the patterns will go. There are 3 lines. First from the anteromedially, orbit from the infraorbital rim and goes inward. Might be to or above the infraorbital and goes to the zygomatic buttress. Second one, infraorbital fissure and goes to the anterior aspect of maxilla and goes to the zygomatic buttress. Third line is goes to the spinal suture extending superiorly and laterally and goes to the frontozygomatic suture. Terminology most commonly used are zygomatic maxillary, zygomatic maxillary common, zygomatic orbital, trimalar, tripod, zygomatic complex, zygoma fracture. Three classification mostly Williams, Trans-Conjunctival and Maxillary. Signs and symptoms is very important. Pain will be there. Persistence on the infraorbital rim, rest mass, epistasis, flattening of the malar prominence, flattening of the zygomatic arch, deformity of the infraorbital margin, displacement of the palpebral fissure, unequal pupillary levels, periorbital mass, ecchymosis, diplopia, enophthalmos, air emphysema, deformity of zygomatic buttress, and ecchymosis on the buccal. And how will you evaluate? Then radiographic, this is the most important called occipital mental view. Then only we can see the 5 lines, Campbell and Tram line. 4 lines are Campbell lines. 5th line is the Tramble line. And how will you treat the zygomatic arch fracture? Main thing, the strong antibiotic coverage. Then under G only we can do all the force reduction test. Reduction of fracture, application of fixation device, internal orbital reconstruction, assessment of ocular modality, soft tissue resuspension, and post-surgical ocular examination and post-surgical imaging. If there will be any problem on the ocular movements, that means the muscle is entrapped to the fracture site. And the approaches, mucosal incision, maxillary trans-conjunctival approach, dermal supra-orbital incision, Gilles temporal, subtarsal, subciliary incision, coronal, subtarsal, Gilles the most commonly, where we put the on the temporal region, preserve the superficial temporal, the layers, superficial temporal, deep temporal fascia, and the temporalis muscle. In between the temporalis and the deep, we inserting the periosteal or pistol elevator or zygomatic elevator. Pass it, goes to the inward of the zygomatic arch and push it. Then only you can reduce the zygomatic arch fracture. These are the two instruments you're using for. One is slow zygomatic and pistol elevator. Then coronal incision that uses on multiple fracture like a Leaford 3 or with the zygomatic arch fracture or frontal bone. I already mentioned that is called a rose zygomatic elevator, malar hook. Buckles working approach that is called approaches by intraoral. Only approaches by intraoral is called Keynes approach. Elevation from the eyebrow, that is the same like eyebrow, and the point fixation from low zygomatic, then zygomatic maxillary and infraorbital. These are the main things. Thank you.